Hi, I'm Amit Patel, Professor of Medicine at Duke University, and I'm joined by Dr. Gary Falk, Professor Emeritus at University of Pennsylvania. And we just completed here at GI ReConnect conference in Aurora, Colorado, the EoE, or Eosinophilic Esophagitis Disease State Summit. And we're here to summarize some of the highlights from our session, offer pearls for providers, and we'll just broadly go in three categories: evaluation for EoE, management of EoE, and then what is the future of EoE. So Dr. Falk, if you want to start, when we evaluate patients with EoE, what are some of the highlights that we talked about?
Yeah, there's a lot of things we discussed, including that initial endoscopy, the changes in the ACG guideline from now on over 10 years ago, whether to get additional biopsies elsewhere in the foregut. And I think the key thing that we want to emphasize is that initial endoscopy, if you do it on any kind of therapy like a PPI or a topical steroid or a diet in someone you suspect has EoE who hasn't had a diagnosis and you do it, you're not sure where you stand if that patient has no eosinophils. Whereas if you do it in someone you suspect and already on a therapy, then you're in a different position. So I think the current guidelines and best practice suggest that index endoscopy should be done off of therapy, if at all possible, and emphasize to the patient why you're doing that way. What other take-home did you have as far as the diagnostic part of the session?
I think we discussed the importance of using some of our standardized nomenclature and approach to evaluating these patients. We should biopsy for EoE when we suspect it, but that includes folks that have normal esophageal mucosa, folks who present for index endoscopy for food impaction. Evaluating the endoscopic appearance of the esophagus is important, and we can use things like the EREFS, or EoE Endoscopic Reference Score, to help standardize our reporting of that going forward. In terms of management, Dr.
Before we get to management,
sure.
Yeah, the other thing about diagnosis, there was also some discussion: is it EoE, is it GERD, is it both? And that's a toughie because it can be one of those three categories. They may have EoE, they may have GERD, they may have both. We didn't get into as much as perhaps we should have, but there's a certain GERD phenotype, which is often obese, often a hiatal hernia, often a defect at the gastroesophageal junction. That may be clues. It doesn't exclude EoE. And in someone with EoE, the tip-offs are someone, especially if it's a young or middle-aged male, often white, with concomitant atopic conditions, that'll clue you in. I think the other push that I think both of us especially agreed on is that in someone who you're not sure of the diagnosis, is it reflux, is it EoE, or both? Well, I think best practice today still suggests that if you're not sure about GERD, you're going to be doing that person off of therapy initially. What are your thoughts on that?
I agree with that as well. Sometimes differentiating or distinguishing the two entities, because they're both common, can be a hard one, and there is overlap in the symptoms that each of them provide. Similarly, we can see some overlap between the two entities, and obviously when it comes to treatment, some of our treatments do treat both of the entities. Yeah. So there are a subset of patients for whom further diagnostic evaluation for GERD might be needed if that's a difficult distinction to make.
One other little point that came up is that in the evaluation of someone for reflux or dysphagia or for EoE, is there a need to get additional biopsies from the stomach or the small intestine in someone who's asymptomatic? We're not talking about someone who has additional symptoms that would warrant that. So what are your thoughts on that, and what are our best practice guidelines suggest should be our standard of practice?
That's a great point. There has been some variability in practice around this, but I think we mostly agreed on, in the absence of symptoms that would be compatible or endoscopic abnormalities, they would typically not necessarily need to biopsy other parts of the GI tract in patients with EoE.
Right. I think the thing to emphasize is absence of endoscopic abnormalities and absence of clinical symptoms in the foregut. If there's overlap, if there are endoscopic abnormalities or foregut symptoms that are hard to explain, by all means. And if you're going to look at the non-EoE egids, then it's important to get enough biopsies, which are not just a couple here and there. It's 4 in the antrum, 4 in the body, and at least 4 in the duodenum. And if you're looking for celiac disease, 6. But again, usually I think both of us felt that in the absence of symptoms suggested that we routinely don't do biopsies in the stomach or the duodenum.
Absolutely. I think it's important for us to be thoughtful and systematic with how we approach that. And when it comes to eosinophils, we talked about the importance of peak eosinophil counts in the esophagus as a potential measure, not just for diagnosis, but to evaluate response for therapy. Are there other things from a biopsy or pathology perspective that are important?
Yeah, I think one of the things that the new ACG guideline emphasized is that there's increase in eosinophils and increase in eosinophils. So if it's just greater than 15, and 15 being the threshold, that greater than 15 can be 16 or it can be 200. And I think that it's probably a little bit of a different status of disease given large numbers versus small. And similarly, the current ACG guideline emphasizes that if a subsequent endoscopy on therapy says greater than 15, that may be 16 from coming down from 20 or 16 coming down from 200. It also may be 200 going down to 180. So that emphasizes two things. It's not enough just to say increased eosinophils are greater than 15. And again, whether it's greater than 50, greater than 100, but there needs to be some enumeration. And the other, we feel that to look at just counting eosinophils is oversimplifying the disease. And that while the Collins EoE-IS, which is used in research, is not practical for clinical practice, we do suggest the possibility of having your pathologist template their pathology reports for simple yes/no of some certain ancillary features, including is there lamina or propria fibrosis, yes/no, are there microabscesses, yes/no, is there basal cell hyperplasia, yes/no, is there superficial layering? And that's an easy thing. That's easier to say yes/no to that than to count eosinophils. And we've done that at Penn. It helps kind of flesh out the big picture without doing a formal EoE-IS score. Is that something you've been doing at Duke or not really getting those other features?
Yes, at Duke, we're trying to work with pathologists on better delineating the presence or absence of some of those features because I think they are important even beyond the eosinophil counts, beyond what we talked about with the manual labor needed to count eosinophils, particularly when they're high. Building on that with diagnosis, we also discussed the index of severity for EoE, or the IC, and this has been enumerated in a mobile app from the American Gastroenterological Association. The idea here is to characterize the severity of EoE at baseline. Any comments on that? How to use that in practice?
I would take my iPhone out like I am right now and go to that. I'm not going to click through that right now, and I would do it with the patient in the room. It's really very simple to do with an electronic medical record. You just input the number. If you have it already as part of your template, which we never had, that's something that it's easier to track. It doesn't take long, and it's again a common language. Where it stands right now, there have been some early studies suggest it may help track disease severity. It's simple, it's easy, it's practical. I like it, and it's easy. How have you done it at your shop?
I agree. I think it's a very simple, easy to use tool. The questions that I think a lot of us are really interested in is how the data from that can help guide how we manage patients. And I think there'll be more data on that. Are we able to personalize therapy to patients, potentially with this as a powerful tool in that regard? And
to demystify it, how long does it take you to do that?
Oh, the app is great. I'd say less than a minute.
Yeah. And the other thing, too, is that if you're not sure how to score some of these things, the app has features to help guide you through the EREFS and guide you through others. But it's really, it's swipe, 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 input, bada bing, bada bang, done. And it'll give you not only the number, but where that patient classifies as mild, moderate, severe. So it's really nice. I think patients like it, too, when they see you doing that.
I know a lot of the excitement about EoE in recent years and going forward is around our therapeutic options and approaches, but the evaluation has really come a long way since the days of PPI responsive esophageal eosinophilia.
Couldn't agree more.
Any final thoughts on evaluation of EoE before we move on to management?
No, I think that the evaluation part in terms of endoscopy and histology we've covered, and we'll talk a little bit about management in terms of our interactions next. So.
Perfect, guys. So for us, I think the name of the game in our summit was the importance of shared decision-making when it comes to the treatment of EoE. And a lot of that's because we're lucky and fortunate to have multiple effective therapeutic options. Thoughts on that?
Well, I think shared decision-making has a lot of good features. Number one, if you just take yourself outside the field of EoE for a moment, it establishes a patient-doctor relationships. The patient and you are working together as a team versus someone being passive and someone being in a submissive position versus someone being in a superior position. So you are working with a patient, and shared decision-making allows you to get to know the patient better and the patient to get to know you, and that builds up a level of trust that, since this is a chronic disease, you're going to be following people over time, and that trust is so important. So number one, it's fun because it allows you to establish really what's the joy that we forget about the doctor-patient relationship. And so in sharing the decision about EoE is that there are multiple choices, and that shared decision-making allows you to, first of all, explain the disease at that initial treatment decision point, which is so important. And explaining the disease doesn't mean getting down into the weeds of a Th2 immune mechanism of disease. It's really explained to patients, you have a disease related to certain foods that you eat or certain allergens in the air that you're susceptible to that leads to leakiness in the esophageal lining, that leads to inflammatory mediators being produced in your body, that then leads to eosinophils and other inflammatory cells coming to your esophagus that, if untreated, leads to chronic scarring and narrowing over time. And that's the whole rationale for why we want to treat this. And untreated, that scarring and narrowing could potentially get worse and worse over time. And with treatment, we think it can do better. Our problem right now is that while we think this happens in almost all people to go to narrowing and scarring, we don't know that for sure. So that's how I set the stage for it. So, and I think in discussing, that's how you do it too. So tell me then how you present your treatment choices to a patient now that you've gone over the disease.
It's one of the most interesting, satisfying discussions we can have with patients. So we talk about the different treatments that are suggested or recommended by the recent ACG guidelines. But up front, we talk about proton pump inhibitors. We discussed in our summit today how the guideline recommendation for employing PPIs in EoE is at double dose. So that would be the equivalent of omeprazole 20 BID or 40 Q day. We have swallow topical corticosteroid options. Now there's an FDA-approved formulation here in the United States beyond the off-label formulations of fluticasone or budesonide that we were using before, and dietary approaches. And we had a lot of conversation and thoughts about this because there's a lot of nuances with this. There is an upfront investment with dietary approaches for patients in EoE, but we discussed the merits, the limitations, the strategies around elimination diets, whether they're 1, 2, 4, 6 food. And then during that initial conversation, I also like to talk about Dupilumab as a potential option. One of the things we did talk a lot about is where to position that in the approach to management for these patients. And there are patients that have multiple atopic conditions for whom Dupilumab could be considered a little earlier in the treatment algorithm, but typically we're starting with the former 3 options that we talked about when we have that discussion with patients.
So one of the most common questions that I get from both patients and other physicians is, what's first-line therapy? So when someone asks you that question, what do you tell them?
That's a great question. I say there's not one right answer.
Exactly. That's the right answer.
And then, but it's a great conversation to have because there are pros, cons, nuances around each of these. And so, sure, at the end of the day, I'd say a majority of patients, we embark on PPIs through shared decision-making as our first-line therapy. They are easy to take, they're cheap, they're safe, good safety track record. But
Doc,
that doesn't mean...
what about dementia and kidney disease? I'm going to die of that, and I have this benign disease of the esophagus. How do you deal with that, which is obviously something we've been dealing with for over a decade right now with PPIs?
Mm-hmm. Not a day of clinic goes by without having that discussion, and that's because obviously that question is not specific to EoE either, right? Obviously we see that with GERD, Barrett's, et cetera. But the key is to summarize the evidence that's out there, right? There's a really nice summary of this in the ACG GERD guidelines from a couple of years ago where things are distilled nicely into several paragraphs. And the idea is the data we have don't really support a causal relationship between PPIs and these terrible things that we hear about, the dementia, the chronic kidney disease, et cetera. The randomized data we do have, while it has its limitations as well, it did not show an increase in any of those conditions with the exception of C. diff for patients on PPIs. And so I have that discussion with them that, the benefits outweigh the risks and there's a good indication for therapy, then by all means we should do it. And with that being said, obviously decreasing the dose to the lowest effective dose, whether that's to treat reflux, esophagitis, or EoE is important down the line. But having that conversation with patients is important because for some subset of patients, that is an important factor in them deciding which treatment approach to take.
Yeah, we want our patients to have the best available evidence for them, and a fear that is a lot media and social media induced. Really, the facts don't bear it out. Mm-hmm. And as you said, there is a need to start at the right dose because if you start at the wrong dose, either too low or too high, it's not in someone's best interest. I like to call it nuclear warfare doses of proton pump inhibitors. That's quadruple dose. But really the equivalent of 20 of omeprazole twice a day. Some studies suggest that's better. There are potential compliance issues. So while perhaps not as effective, 40 is better than 20, and whether at preferably 20 twice a day versus 40 once a day. But the initial dose is the equivalent of 20 of omeprazole twice a day, and you can substitute others there as well. So who's the prime candidate for a PPI?
I think patients that decide after informed discussion of the various options that that's what they'd want to start with. Because again, we know that not all patients will respond to it.
Yeah. And I always tell patients too, the response rate to PPIs, histologic and endoscopic, is about 40-ish%. And that's one option. And I always would tell people, these are the options. I'm not going in order what I would choose. So the second option is topical steroids. And as you've alluded to, we have an FDA-approved product. We've done this off-label for a long time. And there's two issues here. How do you discuss steroids with patients, and how do you get past the fact that steroids equals fear?
So the formulations and doses of steroids we use shouldn't typically be associated with the side effects that we hear about or see for our patients with IBD, for example, that develop these side effects from long-term steroid use. So in EoE, the formulations and doses of steroids we use shouldn't result in that. So we have a conversation around that. Obviously, the administration of these, particularly when we're using things off-label like the fluticasone inhaler or budesonide slurry that's made by patients, getting it right is important. And so working with a clinical pharmacist who we're lucky to have is important with these patients to work on how to take it properly.
I couldn't agree with you more. And instruction sheets and coming at the people from multiple dimensions. Because again, if you don't take the medicine correctly, or if you don't take either steroids or PPIs at the right dose, and the patient hasn't responded, is it because of lack of adherence or the drug doesn't work? Well, the third option before you get into biologics is diet. We had an extensive discussion about that. And start us with, do you give all options on the table, and then do you try to steer people to one or the other, as far as just not talking about diet, forgetting about PPIs and steroids for a moment? So how do you engage in the diet discussion?
So we talk about the different, this is with dietary elimination in particular, right? I don't put adult patients on elemental diets or anything like that, but we talk about using elimination diets and the data that's out there for what originally started as a 6-food elimination diet, right? But there's more recent data that suggested the efficacy of using less restrictive diets that perhaps patients who are more able to be adherent with might take less endoscopies. And so these are those 1 or 2 food diets in particular. But presenting the data out there and talking patients through what this would involve. So if we do a 1-food elimination diet with dairy, if it works, great. You've hit the jackpot when it comes to dietary elimination. But if it doesn't work, here's what we're going to do next, how many endoscopies it might take, et cetera.
Yeah, it's important to go through this up front because when people are given a choice of 1 versus 6 foods and looking to try to hit the home run, and if you hit lightning in a bottle, you're home free. I think most people will opt for that. The other nuance with this is your patient population. So you are at a world that is very rabid about basketball, with a lot of young college students yelling and screaming at Duke games. So how about the college student? How often do college students like the idea of a dietary approach?
So I know you've seen a lot of college students throughout your career as well, Gary, but this is why individualized therapy and shared decision making are so important, because for a lot of college students, it might be their first interaction with the healthcare system, right? If they're presenting with a food impaction, et cetera. And so working with them on what they're able to do. So you could imagine a college student who's busy between classes and parties and sports and clubs might not be one who's able to be the most adherent with dietary elimination at that stage in his or her life. So it's important to really think about what therapy, and again, rationalizing the importance of treating this, but talking about what therapy makes the most sense.
Yeah, and when I talk about dietary therapy at all ages, I point out that if we're going to go down this path, you have to basically commit to if this works, then that's going to be how you can change your mind later on. But there's a lot involved here, especially if you do a 6-food elimination diet. There's an endoscopy potentially every 6 weeks until you find what the food or foods are. And you have to be prepared for restriction in your diet. Now, if it's just eliminating dairy or eliminating dairy and wheat, that's one thing. But if it's eliminating dairy, wheat, peanuts, tree nuts, and other things, do you want to go down that route? And so the response to some might be, I really don't want to use medications if I don't need to. And then you embrace that. If others are going to say, I really am not sure about that, then I try to discourage people from going down the dietary path. Recognize if you go down it and it works, you can always change your mind.
Yeah, I think that makes sense. The dietary therapy, I think there is definitely an upfront investment by the patient and the provider to make that work and get it right up front.
Just something we didn't talk a lot about in a group, but we want to just talk about briefly is where dilation fits in, at least up front. We don't want to talk about it necessarily chronically, but what's your approach to where dilation fits in and how you use concomitant therapy with it or not with it?
Yeah, I think dilation is a very important adjunct therapy. I stress the word adjunct, right? Because dilation isn't going to resolve the inflammation of EoE. So we have to use it in combination, or should use it in combination with an anti-inflammatory therapy approach like we've discussed. With that being said, I'll dilate even on index endoscopy when it's appropriate, because we can obviously treat the inflammatory nature of the EoE with what we've discussed pharmacologically or via dietary approaches. But some of that fibrostenosis will respond best to dilation. The other thing that we should mention is with some of our anti-inflammatory agents, sometimes we can see some improvement in the esophageal caliber.
Exactly. And again, I would tell patients it's like putting a Band-Aid on, number one. Number two, we can give you some discomfort with this, and it's a start low and go slow approach. You don't have to get to the finish line right away. And if you don't get treatment as well, all this work is going to be for naught, and there's studies to suggest that as well. So it really is part of it. I would tend to be conservative, although our guidelines say you can use dilation up front before you start therapy or after. And I often, because of what you said, you'd see esophageal diameter increase just with medical therapy alone, and that could potentially save step dilations because the target goal is 16 millimeters.
With that said, I think it's important when folks may have persisting dysphagia symptoms in the setting of an endoscopic and histologic response with anti-inflammatory therapy, then for us to assess for the possibility of strictures or stenosis that was missed on endoscopy, and whether barium or FLIP can help ascertain that, or empiric dilation. I think that's worth doing. Right.
It's important to emphasize 2 points here. If someone is in endoscopic and histologic remission, but they still have symptoms, is it because it's an unrecognized area of narrowing? We're not very good endoscopists. Even experts are not good at this. This is the part of the EREFS that has the least agreement, and we don't recognize subtle strictures. So the target goal is 16 millimeters. And even at 16, if you have if you still have symptoms, that's when you start thinking about things like hypervigilance, which can occur in this patient population. So there's subtleties to dilation that people should be aware of. Well, that gets to the new kid on the block, which is Dupilumab. Start with it, end with it. Where does it fit in, and how are you using it right now? And then how is the ACG guideline positioning this?
Great question, and an important thing, and I think it's been a godsend for some of our patients. The most common situation or setting I'll use it in is a step-up therapy for our patients that have failed PPI, who have failed topical steroids and either failed or unwilling to do dietary elimination. For those patients, it's been a really nice addition to our armamentarium to treat our patients with the EoE. With that said, I think there's potential other settings where it might be helpful, a little more upfront as well. A couple that come to mind are one where patients have concomitant atopic conditions that can also be treated with the Dupilumab, right? We think about atopic dermatitis or asthma, or, chronic rhinosinusitis, or nasal polyposis. So there's things like that. And then there might also be potentially a role for patients, perhaps younger patients, who have very severe disease up front that has resulted in things like malnutrition, weight loss, feeding difficulties, for whom that may be an option.
Yeah, so while it's tempting to use a therapy less frequent like Dupilumab that is very efficacious, there's not been head-to-head trials with that and other agents right now. The randomized control trial evidence is very compelling. It's also very expensive. So until we know more, most of us are following this step-up therapy. But I can easily see a world in the future where we're not going to do that when we can predict response to therapy. One other thing that I think we want to emphasize in this session is the issue of multimodal therapy. Mm-hmm. So 2 questions for you is that how often do people come into you on multimodal therapy, and how do you approach using more than one drug? And then what do our guidelines tell us about using more than one drug?
Right. So A, more often than I would like. B, in terms of how often I employ it in practice, it's not that common because when particularly we're starting from scratch with patients, we want to see which agent works. Now, if there's reasons for patients to be on other medications for other indications, let's say overlap GERD or reflux esophagitis, that's one thing where the PPI doesn't necessarily treat the EoE or non-response in terms of the EoE. But generally, particularly now with the addition of Dupilumab, prior to that, I was using combination therapy between our other three a lot more often. But now more open to using Dupilumab as single therapy as opposed to trying to combine or use other combinations of the other three.
Yeah, I think you'd agree probably that right now the evidence that 2 is better than 1 is 3 and better than 2 is non-existent. Mm-hmm. And the other part about it is a practical point. The more agents you use, there's more expense, there's more compliance issues, there's more confusion, there's more potential adverse effects. And most importantly, if someone comes into you on diet, steroids, and PPI, and they're better, we don't know what it is. So then unbundling that all becomes hard. So I've taken a pretty strict approach, but I agree with of one at a time. But the settings where you need more than one is that GERD and EoE can exist together, and topical steroids don't treat reflux, number one. And we really don't know. One of the great unknowns in EoE today is if someone has failed all therapies, what do you do? Do you do combination? And really, that's the Wild West. We just don't know. But I think in most clinical practice, I think both of us would recommend not going with more than one drug versus or a combination of medications and diet. Yeah,
it'll be rare instances where I think we're headed that way. The other important thing we talked about is the importance of maintenance therapy, the rationale for it, how we do it in practice. So
I'm going to interrupt you there for a second. Before we get into maintenance, how do you know that a drug's worked? So you've instituted therapy.
That's great. Yeah.
Patient feels better. Are you done or not?
Absolutely not. Right. So there's 3 endpoints we want to look at.
Answer the trick question correctly.
Symptoms. I'm good at trick questions, Gary. So obviously the first thing is symptoms, right? I know at the end of the day, that's really important. However, we know that symptoms have very limited correlation with histologic and endoscopic activity in EoE. So that's why endoscopy is so important in these patients to assess their response to therapy. And that consists of both their endoscopic appearance via the EREFS score, but also histologic activity in terms of we talked about the different things we can use for that, but peak eosinophils commonly. And so the idea is across all 3 of these, we want to achieve remission if possible in our patients.
And does everyone get an endoscopy at the same interval after instituting therapy? Is it different depending on what you're starting with?
Absolutely. So for PPIs, we'll usually do in that 8 to 12 week mark. For steroids, usually closer to 12 weeks. And for Dupilumab, we're usually doing 3 to 6 months after instituting therapy.
Right. And diet?
Diet, 8 weeks. 6 to 8, yeah.
So again, the little nuances that may be hard to remember, it's perfectly okay to refer to the guidelines with that. With diet, the way to think about it, diet, if you don't need to be on an elimination, you'd rather know that sooner than later. So that's really about that 6-week point that you do it. We know that topical steroids, if you go at 8 weeks, there can be some additional response at the 12-week point, so that's where it's 3 months. And Dupilumab, the New England Journal study showed really at 6 months. The reason to do it earlier is if you need to dilate along the way with that and not to necessarily wait exactly 6 months to dilate. But you can't judge response just on symptoms, and that's a common mistake, I think, or pitfall, shall I say, not mistake, that people make because of all the adaptive behaviors. So let's go back to chronic therapy and monitoring people over time.
Yeah, so the idea here, we talked about how to assess the response to therapy. So let's say we have a patient who responds well to a particular therapy. When we do that follow-up endoscopy, endoscopic normalization of mucosa, there's no eosinophils, their symptoms are great. What do we do after that? Let's say they're on omeprazole 20 BID. What do you do with that patient?
So the goal with this, like anything else, what's the lowest dose of therapy to keep you in remission? And again, those components of remission are always the same. It's histologic, endoscopic, and clinical remission. So if you're on 40 and you're in remission, you're going to look to 20. And if you're in remission at 20, then you don't drop down further, because I think both of us believe that until we know more, probably should maintain people on maintenance therapy for that.
When you're talking to patients about why maintenance therapy is important, what are some of the highlights?
I think it's an important point, because if someone feels better, they ask, why do you want to take medication? Well, you don't feel anything when you have hypertension, but that's obviously a disease with much more significant comorbidities than EoE. This is a chronic inflammatory disease that doesn't go away. People don't grow out of it, and the studies to date, although limited, suggest that when you stop therapy, the endoscopic features all come back, even if the symptoms don't, including strictures. So if you've dilated up to 16 from, say, 12 or 13, and you stop therapy, then you go back down to that off of therapy. So you undo the work that you've done. So I try to tell patients, all the work we've done has gone to naught. And so I'd rather err on the side of being conservative, because untreated over the course of decades, it suggests that there's chronic narrowing, scarring, and stiffening of the esophagus that can be more challenging to treat over time. I also point out we don't know that happens in everybody. We think it happens in most, if not all, patients, but we just don't know. So it's okay to tell patients we're not sure. And my bias is to treat aggressively, but that's where that shared decision-making, doc, I don't want to take medicine if I don't need it. Well, I'm not sure I agree with you. I'm not doing it. Then the key thing, you have to basically make sure someone follows with you regularly. In theory, if someone is in remission and on chronic therapy, there's a lot, and once you've documented it, you don't need to keep doing endoscopy. So I think once you're in remission and you're at the lowest dose you can and documented that, then I think it's routine follow-up roughly on an annual basis. And what's the reason for that? There's severalfold. You assess compliance, you assess symptoms, and importantly, in this rapidly evolving disease, you give updates to patients on the disease. What's going on as far as the therapy you're on? Are there any new adverse events that have been described? What are new developments? What do we know more? And this is a very rapidly evolving space. The other part of it that's not said is that it's enjoyable. Again, the doctor-patient relationship, you're touching bases once a year, and patients, when they're feeling good, they're very thankful. And when patients are feeling good, not only are they feeling good, but you're feeling good that you've helped make them better. So I would see patients once a year in the clinic. No one knows the interval of endoscopy to do once you're in remission. It's very arbitrary. It's roughly just guesstimating darts on a wall every 2 to 3 years in someone who's in remission, but we don't know. It's certainly not every 6 months. It's certainly not every year in an asymptomatic patient who's compliant. That being said, there can be loss of response to therapies, in particular PPIs and topical steroids, although we don't know if it's loss of response or loss of adherence. What are you doing?
That's a great point. You brought up some really nice points about the art of medicine, the importance of continuity in that relationship, the rapid developments in EoE over the last decade, and all these are important reasons. Loss of response point you bring up is interesting, because I think it's really important to get good medication history in these patients to assess for adherence as the potential cause. But I have seen several patients in my practice who we've switched therapies on because of what we've perceived as a loss of response. But the other thing you bring up is super important, and that's it's hard to identify which patients are going to be the ones that have a higher risk of progression to fibrostenotic phenotypes that are harder to manage in the long run. And when we think about, going forward, what are our gaps in knowledge? Where do we really want to know more? There's a lot of them, but one of the biggest ones in my mind is the ability to identify these different phenotypes of EoE, identify the different predictors of response to different therapies, with the goal towards personalizing therapy the way we have for other diseases in GI.
So at the end of this discussion, what are your key take-home points to the audience?
I think it's important to always be vigilant for the possibility of EoE. It's a lot more common than we think. It doesn't happen in the stereotypical population that we think of. So
and becoming more common all the time, right?
Very much so. I know we talked about when you were in medical school, was it even something that you had a formal course on?
No. But that was a long time ago in a place far, far away.
But, now it's something that I know forms a huge portion of our practices, and it's something that is really common. So being vigilant for the possibility of it. We talked about biopsying, even if it's not a patient you would otherwise suspect demographically. But if there are any potentially compatible symptoms, biopsying at the time of food impaction as well, making sure we standardize our assessment using tools that we have endoscopically, like the EREFS. We talked about the Index of Severity for EoE, to get that baseline severity as well. In terms of management, the biggest takeaway is shared decision-making, right? Talk in depth about these different potential treatment options we have, because every patient is an individual, right? With their own reasons, their own personalization, their own pros and cons that they would have when we're choosing what therapy to use. We're excited. It's exciting to have Dupilumab as an addition to what we use. It's exciting to have an FDA-approved topical steroid formulation to use when it is covered. And I also wanted to mention there's a lot in the pipeline. I know you've been personally involved with some of the different agents that are in different phases of development. Any comments on those?
No, I think that was the only other point I was going to make too. This is going to get more complicated in coming years. There are different compounds under development acting by different mechanisms. Some will be positive studies, some will be negative, and that's part of the excitement here. And I always like to show a slide is that we're going to try to make EoE for the IBD people what IBD is for us, which is hopelessly complicated. No, it's really not that complicated, but I think the future is bright. And I think this is one of the most gratifying diseases I've taken care of over my career because we have lots of ways of making people better. And the patient is happy, we're happy, the family's happy. So it's a win-win all the way around.
I couldn't agree more. EoE is it's an exciting time for us and particularly our patients with the EoE. And I feel our disease state summit here at ReConnect has really helped summarize some of that and really harness some of this enthusiasm that we have and energy. So, agreed.
Thanks.
Thank you.